Welcome to today's presentation. My name is Corinne Young. I'm a nurse practitioner in pulmonary medicine. I've been in pulmonary for I'm over 20 years officially now, and I will be talking to you about mainly the pulmonary pieces of what we're going to be talking about today. And also joining me.
So hi, I'm Wendy Simmons. I'm a physician assistant in Wilmington, North Carolina, in a rheumatology practice. I've been there 28 years. And my relationship here is I've worked real closely in our town with the PULMs and established multidisciplinary discussion clinics with our colleagues. So I'm excited to present with Corinne today as well, and I'll be doing more of the rheumatology serologies.
We like to order serologies in pulmonary. We just don't like to talk about what they mean. All right, so here's our disclosures. Wendy's a little busier than I am, it looks like. All right, our objectives today to describe the relationship between interstitial lung disease and connective tissue disease, including the impact of systemic autoimmune rheumatic disease, ILD. If you previously knew this as ILD, you are now OLD because they keep changing terms. And if you stay in medicine long enough, you're going to keep getting it changed on you. So get used to that. We're also going to talk about current diagnostic treatment strategies for ILD and analyze emerging therapies for ILD and clinical trial data. All right, so this is our agenda for today. In case you didn't already know, we're going to try to get through these. We do have a lot of slides to get through, so I'm going to try to get that through quickly for you, and then you'll go to your breakout sessions. If you don't know which breakout room you're in, if you ask the staff at the back, they will help direct you. Some of you will be staying in this room with Wendy and I. All right, so interstitial lung disease, there are more than 200 interstitial lung diseases. And if you like to treat interstitial lung diseases, you must also like living in the gray, because there's more gray about ILD than there is black and white. I love black and white, I love rules, and ILD does not follow a lot of them. These patients look like all of our pulmonary patients. They're short of breath, they have coughing, which could be a million and one things, but these patients do have these very vague symptoms. They also have a lot of fatigue and decline in their exercise capacity. They also tend to have some overlapping other pathophysiology related to that inflammatory process that is driving their ILD. So there's also a progressive phenotype of interstitial lung diseases that does cause worsening symptoms over time, and we're going to spend a little bit of time on what that progressive phenotype of pulmonary fibrosis looks like and how we diagnose it. So this is a little older data from 2019 with a prevalence of over 500,000 people diagnosed in the US with interstitial lung disease. This number is likely higher, especially after COVID. With the Delta variant, we saw a lot of ILD, a lot of fibrotic lung disease associated post-COVID. The highest prevalence is in the older populations. We tend to see it more in males than we do in females, but just by a little bit. It really likes, especially specific types of ILD, do tend to like white males over the age of 65 who have some sort of exposure in their lifetime, which we're going to talk about, usually occupational or smoking history. When we look at the gender, age, and pulmonary function index, where patients are diagnosed at stage 1 versus stage 3, this does show that their 3-year mortality is not exactly what you'd want to see. And the big point of this data is to reflect that time is long. Lungs are very delicate. They're exposed to the world, and unfortunately, a lot of damage cannot be undone when it comes to fibrotic lung diseases especially. So there's about a 50% mortality in 3 years for these patients if they're left completely untreated. We used to, unfortunately, a lot of our patients who end up with interstitial lung disease diagnoses will go online, they'll look up a how long do I have to live type question, and they'll see that 3-year graph that shows that they're going to be dead in 3 years. And one thing hopefully you'll be able to talk to them about is don't Google, please. And 2, this is for patients who don't have any treatment options. And up until 2015, we had very few treatment options for ILD patients outside of immune suppression. And some of our therapies even killed them faster. So we do have better therapies now for them. So in pulmonary, when we are getting patients with interstitial lung disease, we are often working backwards and with trying to figure out what caused it. Is there any other underlying diseases related that could be causing this interstitial lung disease? Whereas rheumatology, you guys have a little bit of a crystal ball, because they've got scleroderma, they've got rheumatoid arthritis, or something that could potentially develop into pulmonary hypertension or interstitial lung disease, right? You guys are kind of screening and looking, and oftentimes the first time a patient knows they have an autoimmune disorder is when they've been diagnosed with an ILD. So we're working a little bit backwards. So first thing we try to do is figure out, is there something that we can say caused it? And that's where some serological assays come in that Wendy's going to talk about. And then we start looking at the morphology of it. So at our fingertips, what do we have? Imaging is very important to us in pulmonary. We rarely biopsy these patients anymore. And I'll talk a little bit why we don't biopsy them as often. So sometimes we'll have a bronchoscopy if it looks like it's an infection that's not resolving. A lot of organizing pneumonias are non-infectious pneumonias that are interstitial lung diseases. And we may do a bronchoscopy to make sure there's not something infectious that's driving it for them. And then surgical lung biopsies are fewer and farther between, thank goodness, for 4 patients. But occasionally that is still done if we just can't find, if we need to know for whatever reason exactly what kind of ILD it is. And even then, sometimes we don't get an exact answer. And then the behavior of the disease. Is it stable? Is it improving? Or is it progressing? And we measure that by their lung function, the forced vital capacity. Forgive the one, I don't know why that's there. I think they were kind of combining FEV1 and FVC, but the forced vital capacity is the FVC, DLCO, which is the diffusion capacity of carbon monoxide, and then the 6-minute walk test. And if those are declining over time, and we'll talk about what percentage of decline we consider significant, that's telling us this is a progressive phenotype of lung disease. All right, so when we first look at the etiology, this is a very simplified look at the classifications of interstitial lung diseases. Have you guys all seen that interstitial lung disease tree? I see a lot of nods. If you haven't seen the tree, BI has this amazing interstitial lung disease tree, and each limb tells you these are smoking-related ILDs, these are autoimmune-related ILDs, these are drug tox ILDs, and it kind of helps you really understand what family that patient is belonging to. Idiopathic pulmonary fibrosis is one of the deadlier ones, and also one of the ones that patients are going to bump into online first when they look up interstitial lung disease or pulmonary fibrosis. This is the one your patient's going to see, even if it's not the disease they have, it's what they're going to be exposed to the most online. It's idiopathic. We don't know what causes it. And so patients always want to know why, and we just tell them, we don't know yet. Systemic autoimmune rheumatic disease associated with ILD. This is the old CTD ILD, is now SARD ILD. Hypersensitivity pneumonitis. This could be hypersensitivity to molds. This could be what we call like hot tub lung or sauna exposure. Even patients exposed to like wood reeds and wind instruments, like the moisture in the reed. The feathers, bird fancier's disease, sometimes we would call it. The feather in down pillows or down comforters, down jackets even. We had a patient who kept having HP and we found out it was a feather antigen. He had no birds in the home. It was his down jacket. So those things can happen with hypersensitivity. That can progress to a fibrotic phenotype as well. And then drug tox. In pulmonary, we hate amiodarone more than anything. Next to amiodarone, we hate macrobid the second because we end up with some drug toxicities with interstitial lung disease related to those therapies. There is pneumotox online. If you guys haven't looked there, you can see if maybe some drug toxicity may be coming from a therapy that the patient's on. And oh, by the way, all of our lung cancer patients are now getting CHEK2 inhibitors, which also tend to cause pneumonitis in the process of trying to battle their lung cancer. So we get a lot of drug-induced ILDs as well. As far as infectious disease associated ILDs, these are more the viral infections. And pre-COVID, we would see these influenza pneumonias that would leave behind fibrosis or permanent damage of lungs. And now with COVID, again, Delta variant was the worst. It's been getting a little bit better. We still have patients that end up with organizing pneumonias even after COVID pneumonia. So that's something that we're always looking for. And again, we want to make sure we're identifying them as early as possible. Don't ignore a CT describing any interstitial process. Make sure that they're getting to your pulmonary colleagues or getting repeat imaging at the very least to make sure that this is not the beginnings of something that can turn into something very bad for them. As far as what ILDs you're likely to bump into, most common being IPF, and then the autoimmune, you likely are going to see more of the autoimmune. And then the hypersensitivities, just kind of break down there. So serologies, I'm going to hand over to Wendy.
Thanks. So, here we are in rheumatology, and, our job is to obviously help our pulm colleagues figure out the picture. We love to do labs in rheumatology. We also want to be sure we're getting our stethoscopes out, we're listening to the chest. We see a lot of autoimmune diseases that can help pulmonary find interstitial lung disease as well. We do a lot of labs. As Corinne said, time is lung. Baseline ANAs, ANA panels, if we have any suspicion in our patients, the anti-CCP, rheumatoid factor panels. Recently had a patient sent from pulmonary to me in the past few weeks, and the patient had positive CCP, positive rheumatoid factor, and then the patient ends up in my clinic. I see the patient, and the patient is like, I don't know why I'm in arthritis clinic. So, a big part of our job is educating our patients, but also in our clinics paying attention to what we need to do to help pulmonary in either expediting through with labs to maybe get more specificity as to which autoimmune disease that they have. Maybe also pre-order some tests with pulmonary function, DLCO, the high resolution CT, and be able to expedite them to pulmonary. Certainly, we see a lot of rheumatoid that is really high on the list for interstitial lung disease. With these patients, lupus, Sjogren's. The Sjogren's is a disease is big now. We're learning more. We should have been learning more in the past. These patients with mixed connective tissue disease, anasynthetase syndrome as well, scleroderma. We have patients in our clinic that we're seeing with scleroderma, and these can be really tough patients. So, getting the antibodies, being able to help figure out the picture as well, certainly is going to help our pulm colleagues. The continuation of the etiology and morphology, as Corinne was talking about, different patterns with interstitial lung disease. Radiologist certainly helps that when we're ordering our imaging studies, maybe before we get them to pulm. But we're also following these patients along the way. We're seeing them for their autoimmune disease state. We're also sharing medications. So these patients might be coming back to our clinic with acute exacerbations. So it's important that we learn the ongoing pulmonary fibrosis and how that can continue even if we have the autoimmune disease under control in our clinic. Say if that patient has RA, they're in our infusion suite. We want to be astute to understanding what we're going to pick up for signs or symptoms of acute exacerbations so that we can get that patient back to pulmonary. Also, our patients in rheumatology, they often have more than one autoimmune disease. The autoimmune diseases travel in packs, so we want to be continuing to evaluate those patients as well, understanding what medications that we're using along with pulmonary to be able to treat that patient. But you do see the interstitial pneumonias, the nonspecific interstitial pneumonias, and you see really how our ILD shows up in several of these, scleroderma. Those are the important diseases that we need to help our pulmonary friends understand as well. Corinne's going to go through our imaging studies and some other studies as well.
Thank you. All right, so you guys might see UIP mentioned, UIP pattern. Think of that P as pattern, although it's technically pneumonia is what they're calling it, but that P is the pattern, it's not the diagnosis. So you might see in your imaging report, if you're not looking at the images yourself, a UIP pattern, and as Wendy was showing you, UIP could mean any of these things. Unfortunately, it really doesn't tell you what it is. So that just is telling you that there is this pattern that is specific to diseases that follow, that kind of fall under that pattern. For UIP, generally what they're talking about is oftentimes basilar predominant. So just in case you don't look at your CT imaging, can I move this with me? In case you don't look at your CT imaging, I'll try to do this on the other side too. We tend to see basilar predominant. So this is the chest here, this is the spine here, this is right lung, this is left lung, this is the beginning of the diaphragm, so we're at the very bottom of the lung. Up here, I don't know if you can appreciate from how far back you are, it's pretty smooth. This should just be a black line between where the chest meets the chest, the lung meets the chest wall. And then it starts getting very lacy and rough appearing. That reticulation can turn into fibrosis, honeycombing with patients. But we tend to see this basilar predominant pleural-based disease. When we're talking about a UIP pattern, it can climb up the sides of the lungs and start invading upper lung areas, but oftentimes will first show up in the bases. With NSIP, it's non-specific. It can look like a lot of different things, but usually one of the hallmarks of NSIP is it's a combination of both ground glass and fibrotic changes or coarse reticulation along with ground glass. So ground glass is really anywhere where it kind of looks like somebody smudged chalk, for those of us old enough to remember a chalkboard. Not everybody had that. Whiteboards now and smartboards, but it kind of looks like smoke or smudging, kind of appearance with this coarseness of the interstitium appearance. And this can happen in different areas of the lung, but also can happen in the bases. Specifically, you can have bronchiectasis with either of these areas, either of these disease states. Organizing pneumonias, again, depending on how old you are, we used to call it BOOP, and then it was COP. Now it's COP, cryptogenic organizing pneumonia. And there's several other types of organizing pneumonia that are idiopathic interstitial pneumonias is another term you might hear for them. Basically, they're non-infectious. They are inflammatory pneumonias is how you want to think of them. And they can happen pretty much anywhere in the lung. Also, oftentimes you will have consolidations that look like pneumonia. So you'll have a patient say, I've had pneumonia for 6 months. I'm sorry, what? Nobody has pneumonia for 6 months, or you're dead, right? And so what do you mean you've had pneumonia for 6 months? Well, they keep doing these x-rays and I keep having these, they're not gonna call it infiltrates, but I keep having pneumonia. And sometimes they'll be waxing and waning infiltrates. They keep getting antibiotics. Occasionally someone will give them a steroid and they feel better. And then it comes back and it keeps coming back. And they really don't have infectious symptoms. They don't have fevers. They don't have hemoptysis. They don't have, been hit by a truck kind of symptoms that you would expect with an infectious pneumonia. That's often a hallmark to us. What do you mean you've had 7 rounds of antibiotics and your pneumonia is not going away? Those are patients that may get a bronch to make sure that it's not infectious. But usually those organizing pneumonias are inflammatory pneumonias, which oftentimes, luckily, can be reversed. And patients can go in complete remission and end up with oftentimes no permanent damage. DAD, diffuse alveolar damage, we're going to see usually hemoptysis in these patients. We're going to have a lot of ground glass. So it's all kind of whitish here, and then you're going to have some, because it's an interstitial disease, you're going to have all these interstitial infiltrates happening throughout. And then the last one is the hypersensitive pneumonitis. Usually, and I wish they had a little better picture here, but usually it's a mosaic pattern. So are everybody familiar with mosaic type art, with tiles and things like that? So you'll have an area of density next to an area of hypodensity, and they're all kind of patched together in these segments. And that's oftentimes a hallmark sign of hypersensitive pneumonitis. Sometimes your radiologist will call it out as mosaic pattern, which could be air trapping, which it is air trapping generally, but oftentimes there is air trapping. It's not necessarily that air is trapped, making it hypodense. It's that there's ground glass disease, making the hyperdensity areas contrasting to really the normal lung areas that are not affected. All right, so histopathologically, you can also have this UIP pattern. So again, UIP is not the disease, it's the pattern that we're seeing either in radiology exams or in their pathology results. Now, oftentimes when we are doing biopsies on this patient, when we're doing a bronchoscopy, it's all of the tissue that we can fit inside the head of a needle, right? We're going into the airway, we're sticking the needle through the airway to try to take a core sample of whatever we can get without causing a pneumo and hemoptysis and all that great stuff. So we're not getting a whole lot of chunk of tissue. Open lung biopsy is where they get a thoracotomy, and they usually take 3 different areas. They get it, we collapse their lung in the process. They've got chest tubes. They're in the hospital for several days. Hopefully they reinflate great, they don't have an air leak, and, they go home. So very, very invasive for these patients, and oftentimes would lead to exacerbations of their interstitial lung disease after poking and prodding them. So if you do happen to get pathology on these patients, these are the different findings that you'll have looking at these patients' pathology. Okay, so when we are looking at acute changes in our patients, oftentimes we're going to see more ground glass in acute disease. That inflammation is often acute. It takes time to really scar and fibrose the lung. Not very much time, but it does take time, just like you guys see with arthritis, right? Initially, they may have pain and swelling, but they may not have joint destruction yet. That inflammation is bad regardless of where it occurs. We are going to talk a little bit more pathophysiology, and we're going to have a little bit of A&P a little bit later, talking about where the interstitium of the lung is and where this inflammation takes place. But the chronic inflammation in those areas then cause problems, just like in the joint space, and we end up developing fibrotic disease. And I tell patients, you can't unscramble an egg. So once that fibrosis is there, we can't undo it as of yet, unless they're going for transplant. So the inflammatory mechanisms that push the inflammation in the lung are pushing that inflammation other places in the body, and especially the patients with the autoimmune related interstitial lung diseases, we usually are also going to see some flaring happening simultaneously in their other areas.